Bismillahirrahmanirrahim. Assalamu alaikum class. I welcome you all to another lecture of clinical decision making and differential diagnosis. I am your course instructor Dr. Ghulam Fatima. And today I am going to continue with the last lecture where we were discussing the gastrointestinal disorders and the gastrointestinal pain patterns and the gastrointestinal signs and symptoms. So today we are just continuing the same topic, and we are going to discuss some other GIT disorders or GIT sign and symptoms that can like mimic your musculoskeletal sign and symptoms and then need to be screened during your patient examination. So, as a part of that, we'll be discussing different sign and symptoms, and by like discussing those sign and symptoms, hopefully by the end of this lecture, all of you will be able to differentiate among different patterns of GIT complaints. That what can be the causes behind those complaints and what can be the pattern of those pains. We will be able to differentiate that, and then you will be able to understand the screening process for GIT silent symptom. What are the main clues that can help you to screen the silent symptoms of GIT, and you can include then those silent symptoms in your history taking or your screening process. Then, in the last part of this lecture, and by the end of this lecture, obviously, you will be able to differentiate between the muscle abscess, especially commonly related to your GIT, is source and obturator abscess. So you can differentiate if they are the possible cause of sinus symptoms and the actual musculoskeletal cause is not there. So these are the basic learning outcomes for today's lecture. So starting with today's lecture, first of the symptom we are going to discuss first of all is GIT bleeding. So GIT bleeding is a very important silent symptom, and like most of the time, if the patient is having a complaint of GIT silent symptom, this can appear as a mid-thoracic pain. And if there is mid-thoracic pain, it can also radiate to, if you remember the quadrant of the abdomen, it can also radiate to the right upper quadrant. So most of the time, the right upper quadrant is affected, and if you see the musculoskeletal part, then it can affect your mid-thoracic. So GIT bleeding can cause either mid-thoracic pain or it can cause right upper quadrant pain. Sometimes the GIT bleeding is not that much obvious, like the patient is aware that he is having GIT bleeding, or even the physician or like the person or anyone is aware that there is GIT bleeding. Sometimes, rather most of the time, they're not aware. This is called occult bleeding because occult means hidden. So the patient has hidden bleeding. He is not even aware himself that he has bleeding. First of all, if you need to be sure about that, then sometimes we need some kind of laboratory testings where we have hemoccult test. Hemoccult test are the tests like they can either they can take smears or to test if there are traces of blood in your stool, or in other cases the indirect test in where you can check for the anemia, especially iron deficiency anemia, and those can be tested to check if there is hidden bleeding. So hemoccult test can help you out to understand if there is hidden or occult GIT bleeding. Then the other things that can give you a clue that the patient is having GIT bleeding is that if the patient is having coffee ground emesis, the vomit, the color of the vomit is just like the coffee ground. आपने कॉफी के जैसे दाने लेकिन brownish black सा उनका color होता है. So वो coffee ground emesis, this kind of vomit is like a manifestation when the patient is having perforated peptic or duodenal ulcer. Perforated means that holes through the wall of the your stomach or duodenum. So if there is perforated peptic or duodenal ulcer, they will cause a vomit, which color will be coffee ground. Okay, then there are two things. The color of the blood, sometimes if it is not that much like occult, if the patient is he is observing or he is a witness of blood, and the patient blood is bright red color blood with the stools. So if there is evidence of bright red blood with the stools, then most of the time it is showing you any pathology that is close to the rectum or anus, and this can be most of the time it is hemorrhoids, or it can be anal fissure, or but in the worst case scenario, this can be some kind of tumor or colon cancer. So bright red color blood fresh shows that the blood is like fresh, and it shows that the lower part of your GIT, like rectum or anus, are involved. On the other hand, if the patient is having melena, most of the time patient is not aware of the melena, but if the patient is having, once again I am telling you that melena is dark color, blackish color, tarry stool that is very difficult to wash, and patient may have like stains on their trousers. So that is the melena, and melena is present where this is an indication of large quantities of blood in the stool. So actually the color, blackish color, is due to deoxidized oxygen or hemoglobin. That's why the color of the stool is blackish. So there are two cases. Melena is an indication that some upper GIT, there is bleeding in some upper GIT, that can be your esophagus, or it can be your stomach, or the upper part of your duodenum can be involved. So melena, the color of the is not red, it becomes black due to oxidation. So that's why the melena is an indication that upper GIT bleeding is there, and if bright red blood is there, it shows that the lower part, like rectum or anus, are involved in bleeding. So coming towards the cases where you can have melena, where your upper GIT is involved, there you can have ruptured esophageal varices. It is very life-threatening condition. Simply, varices are as you know that varices are from the term where varicose veins. So actually, the most of the time the esophageal varices are caused as a sequel of liver cirrhosis. If a patient is having liver cirrhosis, then the blood cannot bypass the liver. So if it cannot bypass the liver because liver is cirrhosed, then it is back pumped, and when it is back pumped, it causes the what you can say that delicacy or rupture of the esophageal veins, and there are esophageal varices. So this is a very life-threatening condition, and it is reason of your GIT bleeding. Then if there are other vascular abnormality of stomach, they can also come. Most of the time, there are ulcers. They are a source of bleeding. So if the patient is having upper GIT involvement, and especially if you have some suspicion regarding ulcers, you should ask about the NSAID use. As we have already discussed that NSAIDs are a source of ulceration in your upper GIT tracts. So you should ask about the NSAID use history, and if there are suspicion of bleeding in the lower GIT tract, especially if you are suspicious about anal fissures and involvement of the rectum and anus, then you should also ask about the sexual history, because these are also common in homosexual population. So you should also ask about in a very decent way about the sexual history. Then sometimes the patient will complain of reddish or mahogany colored stools. So there are certain foods like beets, ये जो हम जिसे चुकंदर कहते हैं, they can also cause the color of the stool to be reddish or mahogany. Or sometimes there are certain drugs like iron supplements, and there are many other drugs, and they can also cause the reddish and mahogany colored stool. And sometimes you take some food with added color, that can also cause colored stool. But on the other hand, the reddish and mahogany, if actually you will see they are consistent, if the reddish and mahogany colored stool can also be caused by bleeding in the lower GIT, and especially your colon. So both the possibilities are there. So you have to rule out that either the patient has taken some kind of food or any drugs is the reason of this color of stool, or on the other hand, then the patient can have some GIT bleeding. And in any case where you are suspicious about the GIT bleeding, you need to refer the patient. So another thing is that if you are like thinking about the lower GIT like colon and lower GI bleeding, then another cause of this bleeding can be cancer, and sometimes the radiation therapy, and especially if the females with the cervical cancer and the uterine cancer, if they had the radiation treatment, that can damage the lower part of your GIT, especially your colon and anal and rectum. So you need to ask about the history of the cancer and also the radiation treatment taken for that thing. So that can also be a cause of bleeding in the lower GIT. So GIT bleeding is a serious thing. You should refer the patient for prompt treatment, and the patient should be readily referred to get some proper management of the condition. And it can be upper GIT, where when the stool color will be dark towards black, and it can be the lower GIT involvement in case of like most commonly hemorrhoids and anal fissures. Then the blood will be bright red, blood will be evident. So you need to be very conscious about these changes. Then there are signs and symptoms where the patient sometimes have epigastric pain and there is radiation to the back. Once again, if you remember in the previous lecture, I showed you a picture where it was showing the epigastric pain, and also the radiation of the pain was in the your mid thoracic area was involved. So if there is intense pain in the epigastric region and intense and sharp pain, and it is also radiating towards your back, sometimes the reason behind this kind of epigastric pain can be the ulcers, long-standing ulcers. If the patient is having ulcers and he has not got any proper treatment for that, then long-standing ulcers can cause back pain, and patient may not relate the back pain with the ulcer. So you need to be very conscious about that, that if the pain is caused by the ulcers, so that can be a reason. And then sometimes the patient has the burning sensation that starts from the xiphoid process, and the process and radiates up towards the neck and throat, and the patient may have also some other sinus symptoms like burning sensation, indigestion, and the patient may have like bad taste in the back of the throat. All these can clue towards the heartburn. So heartburn is a sign and symptoms, and most of the time the reason of heartburn is the GERD, as you gastroesophageal reflux disease. So the reason can be GERD. And but on the other hand, the thing which is more confusing is that sometimes the heartburn can be confused with angina or heart attack, especially if the heartburn is accompanied by chest pain, cough, and shortness of breath. These things make the this symptom of heartburn very confusing. Obviously, you will have to rely on other associated sinus symptoms to make a differential diagnosis. And the other thing is, if the patient is not taking any treatment for this, then the chronic back radiation of the symptom will cause actual biomechanical changes there, and there will be actual muscle contractions and a reduction in the spinal movements, and there will be actual positive objective findings. And at that case, the screening between the musculoskeletal and the visceral, especially your GIT and your heart sinus symptoms, will be more difficult to do when your objective findings are positive. Okay, then sometimes the symptoms are affected by the food. Another thing that can be like a part of your GIT screening is that how the symptoms are affected by the food. Coming towards this, if the symptoms, the one clue that can be like helpful for you people is the time. If the symptoms start after half an hour to 90 minutes, then the reason can be your upper GIT or your gastric, most of the time gastric ulcers can be a reason behind them. And if the symptoms develop 2 to 4 hours after meal. Symptoms are mainly your pain. So symptoms develop 2 to 4 hours after meals. Then it can be due to duodenal or pyloric ulcer. So the time can give you a clue. So if the when the duodenal ulcer are there, actually the 2 to 4 hours difference, it is can be complaint like a between meal pain. The patient will complain between meal because in 2 to 4 hours the patient is about to take the next meal in a few hours. So that's why it can be felt like a between meal. Most of the another thing is that your gastric ulcer pain is usually because it start after taking the food 30 to 90 minutes. So it is mostly the other way to state is that is food is will not relieve the pain of the gastric ulcer, but on the other hand, it may relieve the pain of a duodenal ulcer. Okay, the thing when the pain of the ulcer is relieved by the food is obviously when the your part of the GIT is empty, then your gastric juices will act on the walls and that will cause the final symptoms and burning sensation and pain. But when the food is there, then most of your time your gastric juices will act on the food, and that's how the food can help to relieve the symptom. But in case of gastric ulcer, food will again is also a stimulus to the release of gastric juices. So that's why it is said that food is not relieving the pain of gastric ulcer, but it can relieve the pain or signs and symptoms of duodenal ulcer. Then, as we said that duodenal ulcer have a time lag of 2 to 4 hours. So that's why the duodenal ulcer pain is mostly experienced after the midnight, because usually the patient take the meal let's say the patient is taking meal somewhere before sleeping, then at the midnight the patient will be experiencing the ulcer pain. And as we have already studied that night pain is also very well associated with the cancer. But how can we differentiate it that the cancer pain is usually constant and there is no relief, but obviously duodenal pain will be relieved obviously after some time. That's how can we differentiate from the cancer. Then again, if the patient is having nighttime radiated pain in the, if the patient is presenting to you with any radiated pain, like the complaint of radiated pain, the primary complaint of shoulder, neck, and back pain, that are the areas where the pain from the GIT can refer. So if the patient is presenting to you with the referred pain patterns, you need to, especially at the night time, then you need to assess for the effect of food on these symptoms, and also you need to differentiate the cancer as a cause. Most of the time it is not necessary that patient is aware that the food is causing these symptoms. So if the patient is not aware, you need to ask him to observe the symptoms in relation to the food. So you may need to guide the patient, you may need to instruct the patient that he has to observe his own signs and symptoms and become aware how the symptoms of pain, referred pain, are affected by the food. It can increase or decrease, both the cases can be there. Okay, the next sign and symptoms we are going to discuss is early satiety. Early satiety is a condition when the patient is feeling hungry, and he is feeling very hungry, and but he takes 1 or 2 bites of foods and he feels that he is full and he cannot eat anymore. And this satiety is not in proportion to the level of hunger or not in proportion to the previous meal taken. So if it continues for a long time, that patient is feeling satiety after taking only 1 or 2 bites, it can result in the malnutrition. So the reason behind this early satiety, sometimes it can be a manifestation or it can be a symptom of obstruction, some kind of obstruction in the GIT, as food is not properly evacuated from the system. That's why it leads to the symptoms of satiety. Then on the other hand, stomach cancer can be sometimes be a possible cause of that. Then there is a condition which is called gastroparesis. Gastroparesis is a term that's is showing with the condition when there is slowing down. So gastroparesis is a condition when there is slowing down of stomach empty, और आप क्या कह सकते हैं कि stomach की जो motility है वो reduced हो जाती है, ठीक है. Then the early studies also complained faced in case of peptic ulcer and in many other tumors the patient can have complaint of early satiety. And a musculoskeletal problem that can lead to the development of early satiety is if the patient has developed deformity from vertebral compression fracture, like gibbous formation is there and kyphotic curve is there. Then that deformity also, like if there is kyphosis, it also like puts pressure on your stomach. So that's why such kind of deformity, when there is vertebral compression formation, fracture, there is gibbous formation, it can lead to the symptom of early satiety. But obviously, it will also have severe back pain associated with the fracture or any reason causing the deformity. So, and musculoskeletal deformity can be a cause of early satiety, and there are many causes related with the GIT that can cause early satiety. Then constipation. Constipation is a very common problem. What is constipation? It can be defined as, or it can be categorized as, that constipation is simply the patient will be having difficulty in evacuating the feces, or the frequency is of evacuation is less than 3 in a week, or the patient or sometimes the feeling of completely emptying is not there. So these all can be termed as a constipation. Sometimes the patient of the constipation also develop tender sores, major trigger points, and in that case, patient will be presenting with the pain in interior hip or groin, or sometimes thigh pain will be there. And especially if like the pain will be there if the sacral nerves are especially involved, and sometimes if there is like fecal impaction, that can put pressure on the sacral nerves, and the patient will present with the anterior hip, groin, and thigh pain. And there is another extreme like case of constipation, which is called obstipation. Which is seen in the very old people. It is actually intractable constipation. What do you mean by intractable constipation? It means that patient is unable to evacuate the feces by himself. He needs some external help, like as you might have listened about the anemia. So he needs some kind of therapy to get rid of those like fecal impaction. And this is common in the old age, where the patient is unable to remember that when or how many weeks before he like evacuated by himself. So that is called obstipation. Obstipation most of the time, and like almost always, obstipation is related with back pain, and it is a source of back pain. And I have tell you again that because there is fecal infection, it will put pressure on your sacral nerves, so that can be a cause of back pain. For causes of constipation, there are hell lot of causes of constipation, and the most common are decreased water intake, or decrease you can say fiber intake. It can, many drugs can cause constipation, like antidepressants, diuretics, opioids. There are many drugs that can cause constipation. Then the thing which is mostly related to you is the lack of physical activity. Lack of physical activity is a cause of constipation, and the other reason is sometimes the personality or mood change, especially the depression, that can be like cause of constipation. So in that case, how you can help is that the constipation, if it is associated with depression, because depression is a source of constipation. So if it is associated with depression, then it can be improved with exercise. Exercise not only put positive effects, not only it will put positive effects on your constipation, but it also puts positive effects or mood. It alleviates, but is also a mood alleviator. So then with exercise you can help in both situations. On the other hand, there is another cause that a patient, one thing we said that constipation can cause low back pain, and on the other hand, if the patient is having low back pain, then as a result of low back pain, patient will have muscle guarding and splinting, and that muscle guarding and that muscle splinting will cause a reduction in the bowel motility, and that reduction in bowel mobility will cause constipation. So these are vice versa. Low back pain can also cause constipation, and constipation has gone to cause low back pain. So vicious circle will start there. If the patient, as a result of fecal impaction, there will be pressure on the sacral nerves and there will be aching discomfort, especially in the area of your sacrum, buttocks, and your thighs. And as a result of constipation, sometimes the patient have an additional problem of pelvic floor muscles overactivity or spasm. Like pelvic floor muscles can't relax in this condition. They are overactive. They are in the condition of spasm, and the patient may need to consult a pelvic therapy specialist or pelvic therapist may need to deal with this situation. So these are the basic problems that can be associated with the constipation. Then there are certain red flag symptoms, like red flag symptom in case of constipation can be that the clients who have constipation and there is no obvious reason associated with the constipation, and the client suddenly develops something different and something like change in the bowel habits. Even changing sudden and unexplainable change in the bowel habits is a red flag sign. On the other hand, if the patient is complaining of blood in the stools, or having coffee ground basis, or you can say there is evidence of bleeding, GI bleeding, that can be a red flag symptoms. But in relation to your constipation, the red flag sign is that any change in the bowel, sudden change and unexplainable change in the bowel habits, or a blood in the stool, this can be a red flag symptom. Other than the opposite to the constipation, we have the condition which is called diarrhea. So diarrhea is increase in the frequency and liquidity of your feces. So diarrhea is when the patient has the like need to evacuate more than 3 times per day. It is associated with urgency. It is associated with abdominal cramps, and sometimes it is associated with fecal incontinence. It can have a number of causes, and there is a full lot table. I would like you to go through that table in the book. Most of the time, they are associated with drugs, like the most common is antibiotic that can cause diarrhea, and then iron supplements that can be a cause of diarrhea. So diarrhea, like there are many causes, there are many other causes. If the patient is having acute diarrhea, but along with that patient is having fever, cramps, or blood or pus in the stools, that is the manifestation of some kind of severely erosive kind of infection, like invasive enteric infection can be there. So this is the case of acute diarrhea that is accompanied by fever and cramps and blood loss in the blood. On the other hand, if the patient has chronic diarrhea and along with that patient has complained of weight loss, then it can be a clue towards some tumor or some cancer. Or on the other hand, it can be due to some inflammatory bowel diseases. We'll discuss these inflammatory or irritable bowel diseases in the next lecture. Most of the time, if the patient is having inflammatory bowel diseases, there is a relation between inflammatory bowel diseases, and it is associated with arthritis, and not only arthritis, it is associated with skin and eye lesions too. So inflammatory bowel disease is most of the time related with your arthritis or skin or eye lesions. So as I have just mentioned that the diarrhea is caused, and the most common drug to cause diarrhea is your antibiotic use. So not only the antibiotic use is just the recent antibiotic use, sometimes even 6 to 8 weeks, if the patient has used antibiotics 6 to 8 weeks prior in the history, then the patient may develop the symptoms like arthritis, especially that can be the concern of a physical therapist, can develop this system 6 to 8 weeks after the duration of antibiotics or after the use of antibiotics. So there you need to be very cautious, and you need to take a history very keenly and ask the patient about the development of such sinus symptoms. Then another situation where the physical therapist, especially the sports physical therapist, may need to be considerate about is that there are certain athletes that use creatinine supplements. Yeah, the creatinine supplements, obviously it is used to increase the bulk and increase the strength, but it is not totally safe, and even it is contraindicated to use below the age of 18. And if the adult athletes are using the creatinine supplements, they usually develop minor GIT symptoms along with that. They can develop diarrhea, they can develop muscle cramps, and along with that, loss of satiety and weight gain and dizziness. All these sinus symptoms can be complained by the patient. So you need to be cautious about the development of these sinus symptoms. Then another thing is that can be encountered is laxative abuse. There is a very common laxative abuse. Like the users may use 100 laxatives at a given time. Sometimes it is that much laxative abuse is there, especially if you remember their eating disorders, bulimia nervosa, and all that can lead to laxative abuse, where the patient want to lose weight by the use of laxatives. But the chronic laxative use that becomes a vicious circle. That whenever the patient who is chronic laxative user, he tries to stop the use of laxatives, it results in excessive secretion of aldosterone, and the aldosterone excessive secretion of aldosterone will result in edema, and obviously it will be manifested as weight gain. So whenever the patient tries to leave the laxative, there will be a reflex weight gain, and then patient will again switch towards the use of the laxative. So that becomes a vicious circle. So the thing is here that the patient should be trained for the bowel management without drugs. So the aim here is, or our goal should be that patient should learn to manage bowel management without drugs, and how can it can be like physical activity or water intake or fiber intake should be increased. So these should be used rather than using laxatives. Now there is another problem that is fecal incontinence. Fecal incontinence is most of the time it is a sense of urgency, or it is associated with diarrhea, and also associated with the abdominal cramping. So the reasons behind fecal incontinence can be sometimes it can be due to partial obstruction of rectum, and sometimes the reason behind that can be cancer. Then it can be due to colitis. Colitis is obviously the inflammatory problem. Then the radiation therapy, as I have already discussed, that cancer and especially the cervical cancer or uterine cancer, and the chemotherapy and the radiation therapy after that, especially that can damage your colon and the areas. So that will can lead to the fecal incontinence. And then if the anus is lose its main competency, and there is anal distortion, that can be caused by sometimes hemorrhoids, and the surgery for the hemorrhoids can be a cause of anal distortion, and sometimes a traumatic childbirth where they need to there is a cut or there is a tear until anal, that can lead to the anus, that can lead to the anal distortion. So all of these can be a cause of fecal incontinence. So fecal incontinence and other signs and symptoms that can be related to the GIT. Then we have arthralgia. So this is the main domain of a physical therapist, where the therapist will be having arthralgia patients. So the patient simply arthralgia means joint pain. So most of the time, the patients of the inflammatory bowel diseases they develop joint pain, and the joint pain because it has the inflammatory bowel diseases. If you remember, I have already discussed that it is hypothesized that through the lung, which is through the your intestine, and the condition is called leaky gut. When some antigens can pass through that, and that antigens go into the joint, that also cause skin rashes. They also cause like conjunctivitis in your eye irritation. So that situations, inflammatory bowel disease is linked with arthralgia and rheumatic manifestation, inflammatory condition of the joint. So because there is arthralgia, but there is associated synovitis. The associated synovitis is the thing that will lead to the rheumatic manifestations. So peripheral joints are involved, and not only peripheral joints are involved, your axial skeletal is involved, where the patient can have spondylitis, where the spine is involved, and the spondylitis starts with the sacroiliitis, and the sacrum is involved. So actually, all of these is that when that antigen reaches these joints, there an inflammatory and immune-mediated responses started there, and it will lead to the rheumatic manifestation, and kind of then the presentation of this arthritis, which is due to the inflammatory bowel diseases, will be that unlike the rheumatoid arthritis, this is rheumatoid arthritis is symmetrical, but this kind of arthritis is asymmetrical. It is migratory, like one joint is involved, and that is resolved, and then another joint is involved, and it is oligoarthritis. Oligoarticular means that two joints, one or two joints are involved, not more than that. So this is called, actually, as a result of inflammatory bowel diseases, if the patient is having this thing, then it is called reactive arthritis, because it is triggered by some kind of microbial infection from the GIT. So it is called reactive arthritis. So the reactive arthritis is asymmetrical, it is migratory, it is oligoarticular, but the patient has arthralgia, but along with that, he also has some inflammatory conditions. So, I have already discussed that the inflammation is widespread, so the patient will have as an association, he will have fever, he will have weakness or illness kind of sign or symptoms. There will be skin rashes, and there can be conjunctivitis, and there will be nail bed changes where the nail become thin and they leave the nail bed. The nail layers leave the nail bed and they become thin and distorted. So most of the time, the arthralgia, you need to like investigate the history, as most of the time patient is not aware that the joint pain can have some kind of link with the GIT disturbance. But if you will take the history in a proper way, you will come to know that most of the times such kind of arthralgia is preceded by either diarrhea, or there can be arthritis, Crohn's disease, or any other bacterial infection. We have already discussed that bacterial infection and any kind of infection in the last 6 weeks is very important history, and that is a red flag sign. So here again, that the patient has arthralgia, but in the past 2 to 3 weeks, the patient may have developed first the diarrhea or arthritis or Crohn's disease. Actually, any of the inflammatory or infectious diseases can be there. So the affected joints in case of reactive arthritis are knees, ankle, then shoulder, wrist, elbow, and then small joints of hands and feet, and that gives it a presentation. And this is the involvement of these joints are just in that order in which those are written. Okay, along with the joint involvement and arthralgia, the patient also can develop muscle atrophy, patient can develop muscle stiffness, and pain, tenderness, and reduced range of motion can also be there, because obviously if the joint is inflamed and there is synovitis, and if there is long-standing disease, then the joint will be affected, and due to reduced mobility, there will be muscle atrophy and stiffness and all other signs and symptoms. But if the condition is treated properly and the patient is given a proper intervention, then there will be no permanent deformity like the actual rheumatoid arthritis or actual autoimmune diseases. The patient will not have any permanent deformity in case if the proper interventions are given. But in other cases, the patients who develop spondylitis along with sacroiliitis, then their like the condition is progressive and it can ultimately even progress towards bamboo spine. The spondylitis and sacroiliitis, they can lead to the bamboo spine, and you're very well aware that kind of ankylosing spondylitis that develop in the bamboo spine, where the range of motion is lost and there is inflexibility of your spine. Then there is another term which is enthesiitis. Enthesiitis, that is a classical sign of reactive arthritis. In reactive arthritis, and enthesiitis is fine. And enthesiitis is actually inflammation at the site of insertion of your tendon or your ligaments on the bone. I'm again telling you, enthesiitis क्या है कि जहाँ पे आपकी टेंडन या लिगामेंट जाके बोन से अटैच होते हैं, उस साइट की जो इन्फ्लेमेशन होती है उसको enthesiitis कहते हैं. ओके, along with enthesiitis, मतलब ये कि टेंडन की जो अटैचमेंट साइट है, समटाइम्स टेंडन शीथ और जो बर्सा होते हैं और जो लिगामेंट्स जो स्पाइन के साथ हैं वो सारे भी इन्वॉल्व हो जाते हैं. ठीक है, इसलिए तो बैम्बू स्पाइन की तरह जाएंगे. So sacroiliac joints can be involved, and especially the joints of your ankle and your midfoot can be involved. So if the joints of your ankle and midfoot are involved, it can lead to the heel pain. And sometimes the reason of heel pain can be the Achilles tendon insertion site inflammation, or the other end, in the other case, the reason can be the inflammation at the site of attachment of plantar fascia with your calcaneus. And plantar fasciitis is a very common complaint in these patients. So coming towards the another symptoms, that is shoulder pain. So most of the time the patient complain of the left shoulder pain, and left shoulder pain can be caused by either the free air in the peritoneal cavity, that can be as a result of laparoscopic surgery, that there is free air in the peritoneal cavity, or there can be blood in the abdominal or the peritoneal cavity. And we have already discussed about that, how retroperitoneal bleeding, or how your ectopic pregnancy rupture or your spleen rupture even, that can lead to blood in the retroperitoneal cavity, and that will cause a left shoulder pain. So in case of left shoulder pain, the patient will have a sign which is called Kehl's sign. This is increase in the pain when the patient will be lying down and the legs are elevated. Actually, the elevation of the leg increase the abdominal pressure. So increase in the abdominal pressure is the symptom that will cause an increase in the shoulder pain. So that's called Kehl's sign, that pain in the shoulder will be increased when the patient in spine line will elevate the legs. So to screen as a trauma as a source of your retroperitoneal bleeding, you need to investigate about the history of trauma. Any trauma or any blunt thing during games or during accident, or even sometimes minor trauma which has hit your abdominal cavity, and something even staring, it touches your abdominal cavity and something hardly, it can lead to some kind of rupture there. It can lead to blood in the abdominal cavity, and that will lead to the shoulder pain. So we have already discussed that ruptured ectopic pregnancy will also cause retroperitoneal bleeding, and then the patient will have shoulder pain. Along with that, lower abdominal pain will also be there. So the areas that can cause this kind of pain, then pain can be referred to the shoulder from your spleen, from your pancreas, from your liver. Liver most of the time radiate pain towards right side, or the stomach. Most of the time stomach also radiate, although it is lying on the left side, but it is radiate pain towards the right shoulder. We have discussed the pain patterns of all of these organs in our previous lecture. So the in the last part of this lecture, we are going to discuss about the obturator or source abscess. So these are actually sometimes cause of lower abdominal pain, that there is like abscess formation in either your source muscle or obturator muscles. So any infectious inflammatory process which is in your abdomen or your peritoneal cavity, uh, or like we just call peritonitis, that can lead to the formation of obturator or source abscess. On the other hand, if there is like bony infection of your ileum, which is also called osteomyelitis, osteomyelitis or septic arthritis of your ileum, your sacroiliac joint, or your vertebra, even that can the infection can run down, and that can also involve obturator or source muscles. So sometimes the peritonitis can also occur as a complication of abdominal surgery. So if you need to investigation in case of surgery, like for the spinal surgery, if interior approach is used, then there are chances of infection and peritonitis that can involve your obturator or source abscess. So what is the reason why obturator or source muscles are involved in this kind of infection? It is that because they are not separated from the abdominal cavity or the pelvic cavity, as you can see in this picture, that most of the viscera and pelvic cavities are in contact with the iliopsoas muscle. So any infection that is there, or peritonitis, that can involve these muscles, and that can cause silent symptoms. So most of the time, if there is source abscess, especially, that is confined. But in certain cases, that the infection or abscess the infection that can spread to the hip, to the upper thigh, or even your buttocks. So abscesses, if there are any abscesses of the pelvis or retroperitoneal area or abdomen, they can spread infections, and they can cause spinal infection. And if there is spinal infection, then spinal infection जो है वो भी track down कर सकती है आपके muscle को, or even up to the buttock. So buttock या perianal area, groin, or even sometimes in the muscles या आपकी knee तक, popliteal fossa तक भी आपके radiate हो सकती है. So now we are going to discuss the clinical sign and symptoms of source abscess. Obviously, it is kind of infection. So patient has fever, and there is hectic fever. Hectic fever is a type of fever which spikes during a day. मतलब peak पे जाता है दिन में, ठीक है, फिर कम होता है, ज़्यादा होता है, कम ज़्यादा, up down होता है. That is called hectic fever. The patient will have night sweats. Obviously, the patient will have abdominal pain. GIT absent and loss of appetite will be a sign and symptom. Then the patient will have pain. We have already discussed that back pain, pelvic pain, abdominal, hip pain, even popliteal fossa can be involved. And obviously, if the muscle of source muscle is involved, the patient will have antalgic gait. Antalgic gait is a gait which is due to the pain, and the pattern of gait is changed due to pain. And the reason is because the opposite, due to abscess formation, the muscle will be in spasm, and the muscle will be in contracted form, and that can even like lead to the hip flexion contracture. And if you palpate this, you can palpate, you can find the palpable tender mass. So that is the finding in case of this abscess. So to differentiate this abscess, there are 4 tests that can help to differentiate if the patient is presenting to you with pain of the hip and the thigh, and you need to differentiate that actual hip pain is there, actual thigh pain is there, musculoskeletal pain is there, or the patient is having source abscess or obturator abscess. Then the simplest test is that you will gently pick the patient leg off the wall side and tap the heel. So if the patient is having pain and painful expression, especially right lower quadrant pain is there, so that can be a manifestation of peritoneal inflammation. So that simply means that patient is not having your actual hip pain or actual thigh musculoskeletal pain. The pain is due to peritoneal inflammation. Then hopping is very difficult for these cases. Then we have iliopsoas muscles test. And again, if this only in this, the patient will like raise the leg, and you will resist it. Okay, you will resist hip flexion. So if the patient has again pain in the lower quadrant, right lower quadrant, this is an indication of peritonitis. This the same test like दो चीजें, या तो मसल के जो आपका सोर्स है उसके वर्क को आप रेजिस्ट कर लें, दूसरी चीज है आप उसको स्ट्रेच कर दें। इन दोनों केसेस में अगर पेन होती है तो पेन होती है और लोअर क्वाड्रेंट में पेन होती है, तो दैट इज एन इंडिकेशन दैट देयर कैन बी अ सोर्स एब्सेस। सो इन साइडलाइन, to stretch the muscle, to stretch the psoas muscle, you will hyperextend the inward leg in the sideline position, and that will also cause the symptoms in the right lower quadrant of the abdomen. Then another thing is you can palpate iliopsoas muscles. So how you can palpate the iliopsoas muscle? This is the method. That patient will be in the spine line, hip is at 90 degree, knees are in 90 degree, totally supported, and you will palpate the muscle. Now, where will be you will palpate from the umbilicus to the iliac spine. If a line is drawn, from the iliac spine 1/3 of the distance, at that point you will dip down your fingers, and you can ask the patient to slightly flex the legs to have an indication that the palpation, to easily palpate the muscle. So in case of muscle involvement, obviously the thing will be tender, and you will be able to have a palpable mass over there. So this is the method how you can palpate this. Then we have obturator muscle test. In this, hip is flexed, knee is flexed to 90. External rotation is performed at the hip joint, and due to that, this causes a stretch on the muscle, and the stretch on the muscle will cause the pain. And once again, if the region of the pain is your right quadrant, lower quadrant, then it means that obturator test is positive. So when the obturator muscle is involved, then if there is appendix is perforated, or again there is peritonitis or inflamed peritoneum, on the other words, irritates the obturator muscle, then this test will be positive. Sometimes when you are palpating, there will be can be a abscess. On the other hand, there can be hernia. So source abscess, to differentiate between these two, source abscess usually lies lateral to the femoral artery. On the other hand, hernia lies medial to the femoral artery. Hernia is a bit harder and it has very well-defined borders. On the other hand, source abscess is softer and it has ill-defined borders. So that's the way how you can differentiate between these two. So that's the end of today's lecture. The points to remember are that GIT sinus symptoms can confuse with musculoskeletal presentation sometimes, as we have already discussed. And so screening of the GIT sinus symptoms is very crucial. So that's all from the lecture today. I hope you people